So let's see. Okay, I'm going to be talking about mood stabilizers and antipsychotics used during pregnancy, postpartum, and breastfeeding. So to talk about this, so these medications we use mostly for bipolar disorder, for schizophrenia, psychosis. Sometimes we also use them to help the antidepressants work better in depression. So we'll talk about them, and when I mention them, you'll see that you recognize the names because they're much used. So I wanted to start just before talking about the medication, just reminding everyone what happens with bipolar disorder. You know, like it's a very complicated disease to treat in pregnancy for several reasons. Now, one is because the illness per se can be can have recurrences during pregnancy. There is a risk of postpartum depression, postpartum psychosis, risk of suicide, infanticide if you have postpartum psychosis. But at the same time, the medications we use to control the bipolar disorder, some of them can have negative effects for the baby. So you really need to put it in a balance and see what is more risky. Okay, so they did this big study in Sweden, and they compared women with untreated bipolar disorder with women that treated bipolar disorder during pregnancy, and also a control group of women that didn't have bipolar diagnosis. And they saw that the women with bipolar disorder, whether they were treated or not, they were more often smokers, overweight, and misused alcohol and substances. And also both groups of treated and untreated with bipolar disorder had an increased risk of C-section, instrumental delivery, and non-spontaneous start of delivery and preterm delivery, which is important to know. You know, there is a risk with the diagnosis of bipolar disorder. But what was more interesting also is that if it wasn't treated, there was a higher risk of small for gestational age, microcephaly, and hypoglycemia in the baby. So another reason to treat it and make sure that the woman is stable. And I always like to mention this study because there were some, initially they thought that actually bipolar disorder was getting better during pregnancy, but it was getting worse in the postpartum. Then there were some retrospective studies that suggested that maybe it wasn't getting better during pregnancy and then there was more risk of having a recurrence in pregnancy. But this was the first prospective study, and what they did in Massachusetts General Hospital, where they have a center for reproductive psychiatry, they evaluated women with bipolar disorder that were stable at the time of the study started, and they came for a preconception evaluation. And women were advised about their medications, about the risk of their illness, and women decided what to do. If to take the medication or not to take it. 2/3 of the women decided not to take the medication and 1/3 decided to continue the medication. But what they saw is very interesting, that 70% of all the population of women was found to have one episode of illness during pregnancy. Either they were on medication or not on medication. And this episode was most likely a depressive, dysphoric one. But the risk was 2.3 times greater after stopping the mood stabilizer treatment. And the women who stopped the mood stabilizer spent more time of their pregnancy in a mood episode compared to women that took the medication. And what is also very interesting about this study is that the women that stopped the mood stabilizer abruptly relapsed faster than women that tapered it off gradually. So this is very important because we know that women find out they are pregnant and they stop their medications, you know, and that put them at a very high risk of relapse. Then there is schizophrenia. And although we don't know really well how schizophrenia behaves during pregnancy, these pregnancies should be considered high risk because women can become psychotic, and during psychosis there can be fetal abuse, neonaticide, and inability to recognize signs or symptoms of labor, among other things. Women can have like a poor judgment, might not recognize their illness, and put themselves at risk in many other ways. So there is an association with schizophrenia with malformations and fetal demise that seems to be separate from the risk of their medication. There is also risk of relapse if they stop their medication. There is a higher risk of unwanted and unplanned pregnancies, substance abuse, poor nutrition. We know that some of these women have lack of social support, and what I mentioned before, poor insight and cognitive impairment. And that takes us to talk about postpartum psychosis, so risky. It's a psychiatric emergency. There is a higher risk of suicide and infanticide. There is also increased risk of delayed social, emotional, and cognitive development in children of mothers with postpartum psychosis. And the incidence is 1 in 2 cases per 1,000 births. However, if it's associated with bipolar disorder, the risk is much higher. Usually it's abrupt. It starts within the 2 weeks after the baby is born. And the symptoms, they look like the woman is alternating between being more or less okay, but then she's irritable, she doesn't sleep, she has mania, depression, she has delusions, she's confused. So it looks like what we call in psychiatry a delirium, that it can be associated to medical causes. So you need to rule out medical causes. And which was very interesting is that 50% of the cases have no prior psychiatric history. So that's very important to keep in mind. Yes, Megan?
Can you speak at all to the case that just hit the news on that mother, and she was like 9 months postpartum?
Yes. So that's very different, in terms of like, anyone that hears about the case and knows about the subject can know that this woman was sick, She clearly had psychosis. However, we don't know the story, we don't know when it started, there are so many unknown things about what happened, but the presentation in the moment seems very much like a condition of postpartum psychosis,
Do you
we don't know if.
Do you think she'll be charged?
I'm sure she will be charged.
You think so? So what basis does like a postpartum psychosis diagnosis have on criminal liability?
So the thing is, like, if you can show that in the moment of that she did it, she didn't have, she was not in touch with reality, she couldn't distinguish between right and wrong, you can make a case that she is not, she can be charged, but she might need psychiatric treatment, she might be in a psychiatric hospital. However, we know how this goes, we see it in other cases, and usually a lot of women get charged, even though it's clear that they have postpartum psychosis. So it's really sad. That's why I included this, because I think everyone in this community of dealing with women with mental illness in the peripartum period is very shaken by this case, because it shows us what this disease can do, but the rest of the population doesn't believe it, that's the problem. Mm-hmm. There's not enough awareness about it.
Thank you.
Sure. So when you have a case of postpartum psychosis, there are different possibilities. It can be something organic going on, but most likely it's associated to bipolar disorder. And with bipolar disorder, 90% of people have at least one episode, one relapse during their lifetime. And even with treatment, 73% relapse within 5 years of the initial episode. So you will always want to rule out any medical causes, you know, but women that already have a history of a postpartum episode, postpartum psychosis, have an increase in risk from 1 to 2 in 1,000 in the general population to 1 in 7. So that's very important to know. And most of these women will end up developing an episode later on in life. But there is a subset of women that just have postpartum psychosis. So they just develop during the postpartum this episode. And then there is the most severe scenario of suicide, no? And we know that it's rare in the postpartum period. However, it's the leading cause of maternal death in the first year postpartum. And we know that women think about it. There are studies that show that actually women think about it more than what they act on it. But 1 in 7 deaths are due to suicide in the first year postpartum. So that's a lot. So I wonder if anyone knows about this, the dysphoric milk ejection reflex. Have you heard about it? So I just wanted to mention it. There is not much evidence about it, but I thought I see it sometimes, you know, and I thought if we get all the anecdotal cases that people have, we'll have much more information about it. And what it is that women, when they are breastfeeding, they have negative feelings, you know, they can feel depressed, irritated, restless, angry, panicky, very anxious. And then it's more when it's the letdown of the milk that happens, and then it goes away. But in some severe cases, women may even feel suicidal when it's happening. And sometimes it co-occurs with depression and anxiety. And it can happen that it stops happening with time, but some women have them through the whole breastfeeding experience. And we don't know why it happens. It seems that oxytocin is implicated in it. So oxytocin usually helps women to feed, to warm, care, and protect their babies, but can also trigger aggression and the fight-flight response. And it seems that in the dysphoric milk ejection reflex situation, it activates that, the fight or flight response more. So we don't know really why it happens. It might be associated with stress during pregnancy, history of trauma, the use of oxytocin during labor, or use of epidural. We don't really know very well, but and we don't know how to treat it. What we know, what we think is to redo the experience in a positive way, you know, so promoting safety, doing skin-to-skin contact and massage, mindfulness, self-care and nutrition. It seems to help, but I just wanted to bring it up because I hear it. If you ask, you'll hear about this. I thought it was important to mention. So talking about antipsychotics and mood stabilizers, we have several, like you see here, the list. And so with the antipsychotics, we have the older ones and the newer ones. We have a lot of information with the older ones, less information with the newer ones, but we are having more and more cases of women that use them. With the newer ones like risperidone, ziprasidone, olanzapine, aripiprazole, lurasidone, all those, we use them a lot to augment treatment of depression. So it's not just, and as a mood stabilizer. So it's not just for psychosis, we also use them for bipolar disorder, for depression. There's also quetiapine that has a lot of good effects on anxiety, and we use it also sometimes for anxiety or sleep. So it doesn't seem to be an increased rate of congenital malformations with antipsychotics, They did a big study, a Medicaid study, and they didn't see an increased risk of malformation after they controlled for confoundings like maternal, mental, and physical diseases, except for risperidone. They saw a small increased risk of malformations with risperidone. But even the authors say that maybe this was by chance because it was so small, and also they had to run so many tests to get to a significant association. So it's really in question. I don't think at this point we can stop using risperidone in pregnancy because of this. There is an increased rate of poor adaptation syndrome, the same done with the antidepressants. That is, when the baby is born, the baby can feel a little bit, can have a little bit being colicky, irritable, sleeping problems, feeding problems, but it goes away within a week. This also can be seen in the general population. So it's not just with these medications. And we don't have so many data about the long-term effects. So we use a lot of the antipsychotics also during pregnancy, because if you will see now that with the mood stabilizers like lithium and others, there is more risk associated to it. So, but some women will really benefit from lithium. And in Europe, they use lithium as #1 mood stabilizer in pregnancy. So in the 70s, there was a registry. It was a voluntary physician reporting database, and they saw a very high risk of cardiovascular malformations, particularly one that is called Epstein anomaly, that is very severe. So everybody was really concerned about using lithium. In the early 90s, they revised this data, and they saw that actually Epstein anomaly was less than what they thought before. So if it's in the general population is 1 in 20,000, the risk with lithium was 1 in 1,000 to 2 in 1,000. A recent study in the Israeli Teratology Information Service didn't see this association when they took away the cardiovascular malformations that resolve spontaneously. There are certain it's called the oh my god, the ventricular and atrial. They have like this communication between the two sides that actually is very small and closes by itself. So if they took that away, they didn't see an increased risk with lithium. But still, you have to be careful because it's not just the risk of malformation. So first you have to do a high resolution ultrasound to make sure there's no malformation. You need to follow the lithium levels through the pregnancy. There is a concern for lithium toxicity later on as the pregnancy progresses, because the lithium equilibrates across the placenta and it's equal between mother and fetus levels. So there are some possible risks like polyhydramnios, thyroid problems, renal problems, preterm delivery. So you have to be aware of that. And we don't know what happens in the long run to children exposed to lithium. We don't have enough information. But the problem is that actually the anticonvulsants that we also use them as mood stabilizers, and I'm talking about carbamazepine and valproic acid in particular, that carbamazepine is Tegretol and valproic acid is Depakote, they have a high risk of malformation. So in some countries, like in Europe, in some countries, Depakote is contraindicated in pregnancy because of the risk of malformations. The other thing is that they noticed that it wasn't just the first trimester. When a baby is exposed to valproic acid all through the pregnancy, the children can have neurobehavioral effects in the long run. There is risk of lower IQ, of autism. So you want to be very careful and not use it in pregnancy. So this is the only medication I would say that you need to change in pregnancy, really. All the other medications, you can put it in a balance and see what is more risky, and having in mind the history of the mother, like what she tried in the past, you might be able to use them, but valproic acid shouldn't be used in pregnancy. Lamotrigine is another mood stabilizer. It's called Lamictal, the brand name. And when used as monotherapy, like just Lamictal, it's not associated to major malformations. We have a lot of information about these medications from the epilepsy world because they use also for epilepsy. And the data is very reassuring. And actually, I'm using more and more lamotrigine in pregnancy to treat bipolar disorder and sometimes to treat depression too. So all the medications are secreted into breast milk, but as I think I said this last time, that what the baby gets through pregnancy is so much more than what they get through breastfeeding, that for very few exceptions, it doesn't make sense to change the medication when the mother is breastfeeding. And the current guidelines really don't reflect the current data, so you have to go to places like Mother to Baby, Massachusetts General Hospital site, or other sites to look for information. So I think we spoke about this last time. You always will try to use the minimum dose, always one medication during breastfeeding, always consider if the baby is a term baby and it's a healthy baby and will be able to metabolize the medication. And you will monitor the baby closely for side effects. And when you choose a medication, this is the same for everything. You will choose one that the woman had a prior response in the past, that the baby was exposed in pregnancy, if it was. The side effect profile, I always make a lot of big emphasis on that, because many of these medications are sedating. And that's very concerning for me, to have a woman with a baby, breastfeeding the baby and falling asleep at that time, you know? So I'm always very careful to try to use the least sedated medication possible. And you will use the medications that we have more data about. So the American Academy of Pediatrics says that valproic acid and carbamazepine are compatible with breastfeeding. However, in the literature is described hepatic toxicity with both of them. So I think we need to be cautious with them. Lamotrigine accumulates in breast milk. And there is with people that use lamotrigine, they can get a very bad rash that can be severe and life-threatening, that is called Stevens-Johnson. So there was the theoretical risk, what if the baby gets it? So that's why for a long time, people weren't breastfeeding with Lamictal. Now there are more and more data of women breastfeeding with lamotrigine, and so far has been safe. No report in the literature about Stevens-Johnson's in babies. And lithium, the use was discouraged for many, many years because of possible side effects in the child, like lethargy, hypotonia, hypothermia, cyanosis, EKG changes. But new studies are showing that when you use lithium alone, or maybe with one medication, it can be safe, and we'll talk more about that. For the mood stabilizers, you need to check their levels in the baby, and actually that's changing. There are some experts in the field that say you need to check levels in the infant, and some experts that say let's just monitor the baby clinically and see how they are doing. And if needed, we check levels. So there is a little bit of data about lithium and breastfeeding. They saw that the concentrations of lithium in infant serum, breast milk, and maternal serum follow approximate rules of half, so it tends to concentrate in the infant. But it seems that overall the levels were low and well tolerated. And they saw some changes in the thyroid hormone, BUN, and creatinine, but didn't have any significance. So what they say is that should be considered in selected women. So the women should be stable, should use just lithium or a simple medication regimen. They should be able to adhere to the infant monitoring recommendation by the pediatrician. You need to have a pediatrician who is on board, and the baby needs to be healthy. in those situations, you can breastfeed with lithium. And I've had patients breastfeeding with lithium. And so far, so good. So, but you need to follow the mother, the baby. You need to make sure the baby is well hydrated, the mother is well hydrated. There's no vomits, no diarrhea. So the baby needs to be healthy. In terms of the antipsychotics, as I said, we have the old ones and the newer ones. The old ones seems to be low in breast milk. The newer ones, we have less data, but the data we have so far seems to be reassuring. The only one that you should be more careful is clozapine. Clozapine is an antipsychotic that we use for treatment-resistant patients. So patients that don't respond to other antipsychotics. And it seems to concentrate in the baby serum and in the breast milk. And there is a potential risk of agranulocytosis that is a very severe form of blood disorder. So you have to be very careful and not breastfeed with clozapine. I think I mentioned this the last time in terms of using hormones for postpartum illness. We don't know the full story about this, actually. There is a lot of risk of adverse effects with the estrogens and in the postpartum. And so it's still experimental. It's in research. It's not approved as treatment. And there were two old small studies that spoke about using estrogen in preventing and treatment postpartum psychosis. And what they saw in those cases is that the levels of estrogen in these subjects were like levels of menopausal women. And after they gave them the estrogen therapy, the mood got better, the psychosis and the cognitive symptoms got better, and the estrogen level got also better to more women, levels of women of reproductive age. But a more recent trial failed to replicate these findings. So this is still very early in research, and mostly it's because of the adverse effects for the mother. So you have to be very careful. I'm not sure if I mentioned last time about ECT. I think we spoke. ECT is a treatment of option for women pregnant and postpartum with severe mental illness, women with severe depression, anxiety, psychosis, mania, that they can't eat, they can't drink, they are catatonic or have high risk of suicide, violence. So you can use it in those cases. There is some reviews of the literature that suggest that the adverse effects for mothers and fetus are very low, although it can still happen. Women, after having ECT, they get confused, have memory loss, headaches, post-ECT, pulmonary aspiration. So I had a patient that actually wouldn't remember me from one session to the other. And she used to see me very frequently because she was very sick, and because of the ECT, she couldn't remember me. There is also the risk for the babies. There is risk of arrhythmias, premature labor, and fetal sedation due to anesthesia. In all the literature, there is just one case of miscarriage and one case of fetal death due to status epilepticus. Then there is TMS. That is a very promising treatment. It's non-invasive. We have small studies available, but seems to be very promising for perinatal depression. It's well tolerated in women with postpartum depression. In pregnancy, no fetal adverse effects were seen so far. But as I said, we have very small studies available. And they saw improvement of symptoms of depression over 3 to 6 months of follow-up, which is good. And the remission rate was good, from 66% to 90% in open label trials. The only thing with TMS is that you have to go 5 times a week for a period of 4 weeks, and then you have to follow up to maintenance treatment. So it's a commitment. And this is something I like a lot, like therapy. It's inexpensive, it can be performed at home, there is low risk of side effects, and it's helpful for both seasonal and non-seasonal types of depression. And it seems to help women that are depressed in pregnancy and postpartum. So I think this is something to keep in mind. I use it as an adjunct to medications. I don't use it as alone as treatment, unless it's a very more kind of mild case, but I see a response to it when it's associated with medication. And I wanted to mention some of the complementary health practices, So there are a lot of supplements out there, vitamins, and they're not so well regulated, the supplements, so we don't really know very well if they are safe or not safe in pregnancy. Here I mentioned some of them that we know are okay to use in pregnancy, but you have to be very careful. Women think because it's natural, they say it's natural, so it should be safe. That's not really the case. It's the same situation with cannabis, like we know that there are risks. So in this case, if omega-3 fatty acid is well tolerated and may help reduce depression during the perinatal period. Usually what it's helpful to use as an adjunct to other mental health treatment, not just using this as treatment for perinatal depression. So this is something that you can add and it's helpful. Then you have folate. So there are some studies that report an association between low folate and increased risk of depression. There is a lot of inconsistencies in terms of results, but there are some women that have a genetic deficiency of an enzyme, that what the enzyme does is converts folic acid into the active form that is L-methylfolate. So if you don't have that enzyme, or if you have it in very low levels, you might not get the active form of folic acid. So in those cases, it seems to be helpful to supplement with L-methylfolate. And so I think that this is important to know. It's important also to supplement folate for the risk of malformations with the mood stabilizers. With if somebody's on valproic acid or tegretol, they can have more risk of spina bifida and encephalia, and in that case, using folic acid is helpful. And actually, you use folic acid for every woman that is pregnant, but you will need to use it in higher levels for those women. And vitamin D, we give supplements during pregnancy. The data supports to use it when you have a deficiency of vitamin D. We don't know what happens in women that have normal levels of vitamin D and are depressed in pregnancy. Will they get better if you add more vitamin D? So far it's not recommended because we don't know what happens in those women that are not deficient with vitamin D. Then nutrition is so important, like having a healthy diet. It's very, very important to have a better quality of mental health. I had a patient, very interestingly, that she had rapid cycling bipolar. She was the one that was on ECT. She tried multiple medications. During her last pregnancy, she decided to follow a strict diet that was basically very like a Mediterranean diet and very healthy diet. And her symptoms decreased so much. So it's hard to know if it was the diet or what it was, but I always remember her when I think about nutrition and how important it is to have a good nutrition to improve mood stability. And then the physical activity that is so important, to help with mood. And once a woman, so during pregnancy and uncomplicated pregnancies, and after postpartum, when they are cleared by the doctor, they can restart doing physical activity, and that should help to improve their mood in perinatal depression. So any questions, any thoughts? I guess basically, like with all the medications we have, what I want to say is that most of them are okay, to use. And as I said, the only one that I wouldn't use in pregnancy is valproic acid. So we have so many others that can be helpful for women, and I think there is a lot of education that needs to be done. A lot of, awareness that you can use medications. It's a risk benefit, but I think people don't think again about the risk of mental illness during.
Do you think a lot of OBs are comfortable prescribing psych meds during pregnancies?
I think it can go either way. My experience when I used to work in an OB clinic, my experience was that the OBs were more comfortable than the psychiatrists that don't have experience in perinatal psychiatry. But sometimes it's very random. Like now I get patients that are, oh, my OB told me not to use this, and it's really a problem because one thing that I know, and it's also described in the literature, is once somebody tells the patient that a medication is risky, it's so difficult to undo that. Like I can tell them as much as I want, but if somebody plants the seed in their mind that medication can affect the baby, it's very, very difficult to really to make them think in another way, So
yeah, I mean, especially for anxious mamas.
Totally. And that's what I always talk with students about, how you give the information to women about medications, about their disease, like how it will affect the baby, because they get so anxious with everything you say, So, but you have to tell them the truth about things, So I think you have to be very empathic and understand where they are and try to understand their fears and help them understand the real data that we have.
Ariella, I just have a quick question.
Yes.
You mentioned omega-3, you were talking about vitamin D, omega-3, and then there was another supplement mentioned in your slides. What was that one?
Folic acid.
Okay.
So the multivitamins have these things on them.
Mm-hmm.
The question is like, does the woman need a higher dose or not? So we know for certain conditions, like for women that take some of the mood stabilizers, we need to increase the levels of folate. Then for women that have vitamin D deficiency, they need a higher dose of vitamin D,
Mm-hmm. Which I think we all do in Montana.
In every place, I think, in the US. No, not in every place, but I think it's very common.
Yeah.
Yeah. So yeah, I think it's so important to know the risks of the disease. I always try to educate people about the risk of not feeling well or having possibility of have postpartum depression, psychosis. I just saw a patient yesterday or 2 days ago, severe OCD, very severe OCD. And she's pregnant, she's about to deliver soon in 2 months. And I was so concerned because several reasons, like one is that she was like saying, oh, I hope that after the baby is born, it gets better. And I was thinking, no, it won't get better, it will get worse, you know? And I told her, and then I was faced with the fact that she was an anxious person, and I was telling her that her condition can get worse, you know? So I was like, oh my God, I'm making her more anxious. But I felt I needed to tell her that so she can treat it in the right way. But yeah, it's really, really important to treat these women because they can feel so much better. And I think all of us know that, you know, I'm not saying something that we don't know. That once you get them to feel better with the right medication, the right treatment, they can be really enjoy their children. And that's something that they might not feel when they are sick. Any other question? So I think next time we will be talking about ADHD. So I think that's another important issue. Like recently, everyone I see thinks they have ADHD.
It is
So
very popular right now. It's going around. I don't know if it's TikTok or what, but everyone has a ADHD diagnosis all of a sudden.
Yeah,
yes.
I see it all over social media.
Mhm.
Yeah. So we'll talk about the risk of illness and the risk of the medication and the benefits of treating somebody during pregnancy and postpartum. So I think we have how many more times? 3 more times. Then we'll talk about eating disorders another time. I think will be good, you know, like women gain weight during pregnancy, and if they have an eating disorder, it can be very stressful for them. So there can be a reactivation of their eating disorder. And I think the last one will talk about complex cases, and I will ask everyone to bring a case. Or
Is the next one on April 5th?
I think so. Yeah.
All right, okay.
Perfect.
Thank you.
Good.
Well, thank you.
Sure. Sure. I'll see you next month.
Bye.
Bye, Ariella.
Bye.
Thank
Bye.
you.
Sure. Bye.